Well, first of all, many kudos to Guillaume. Really nice and excellent organization. I'm very happy to be here to share with you this proposal that I believe it's very important, mainly, not maybe because for the, sorry, maybe for the experts who are already doing really nice things, but maybe for people who wants to start doing UBE, right, in a very systematized way. Okay. So first of all, we know that, you know, this technique requires an advanced hand-eye coordination and dual portal proficiency, demands rigorous stepwise learning, and the progression should go, in my opinion, not only my opinion, but, you know, from the research the literature I've reviewed, should go naturally from lumbar to cervical and then thoracic procedures. That should be the natural way you should start doing UBE, okay? So let's talk about the background, you know, because as a matter of fact, you know, in all these meetings and congresses and reunions, it's the same question always. How do I start doing UBE? Which is the best case to start doing UBE? What's the learning curve? How many cases do I need to do this or to do that procedure? So some learning curve studies suggest number of cases, of course, in the literature. Let's say, I don't know, 15 cases for decompression, 50 cases for cervical, 100 cases for fusion, something like that, okay? And these studies are normally based on a single surgeon experience. But then we have some studies that use more statistic methods, like, for example, the Kusung method, cumulative sum, with learning curve, risk-adjusted, or multivariate analysis. And the Kusung method is not, you know, something that was invented yesterday. It's a really well-known statistic method to, you know, try to measure objectively how many things you need in order to achieve some objective, okay? So this kind of method to, you know, use it for learning curves is not commonly applied. Thus, there are no general recommendations. Everything that comes to you is because from our goodwill, you know? Okay, maybe 15 cases to do this, 100 cases to do that. So since we lack comprehensive training programs, we propose this really nice 10-tiered progressive stepwise method of learning UBE. It's an article I published with my dear friend Elsa Gonzalez and also our master D.A. Choi in the Asian Spine Journal. So I invite you to review it, to learn from it, because I believe it's really interesting. So this is the ideal difficulty progression to start doing UBE. Lumbar, and in our opinion, you should start doing the most, you know, simple operation in the lumbar region, that is ipsilateral recess decompression, the first surgery. Then you go with cervical, starting foraminal decompression, and then, with many experience, thoracic, you can start doing hemilaminectomy even before you're doing transforaminal approaches. This is not something that I invented out of thin air, okay? It has a background, okay? It is about technical complexity, frequency and prevalence of the cases. Of course, we agree that thoracic procedures are not that common, you know, compared with lumbar procedures, of course. Risk profile complications, literature, of course, and learning curve and case volume. So this is the 10-tiered, this is the UBE journey, okay? This should be your journey in order to come from a beginner to a real master. So for me, it's like lumbar, cervical, and thoracic. And we are going to talk about tiers or generations, okay? The first tier in the lumbar region, the ipsilateral recess decompression. Then disc herniation, then bilateral decompression, then extraforaminal approaches, and finally fusion. In the cervical region, 3 tiers or 3 generations. Foraminotomy, discectomy, bilateral decompression. In thoracic region, which is of course the most complex pathology in this region, in this kind of procedures, first thoracic bilateral uni decompression and then transforaminal approaches, okay? That should be the difficulty progression. So this is like more detailed. And I think this is really interesting and it can help you to start your UBE journey, okay? First tier, ipsilateral recess decompression. You can start with L4, L5, S1 level. Second tier, discectomy. And here, like I said, it's really in detail. You can start with the simple disc herniations, right? Paracentral, recessal. And then you can follow with central, migrated, and redo surgery. And this is maybe when you are ready to, do bilateral decompressions, you can introduce the right-sided approach. That is something that my friend Ashwin and I normally insist so much because the philosophy of approaching is different. Then the third tier, bilateral decompression, and then you can introduce the contralateral approach, the sublaminar approach, then the paraspinal approach. Start, of course, with L1, L4, because the extraforaminal approaches are pretty different if you go from L1 to L4, anatomically speaking, than if you go for L5 S1, because of the presence of the ala sacra, okay? So it's another whole different surgery. Finally, TELIF, right? Start with interlaminar, going like a P-leaf, and then a true transforaminal T-leaf, right? This is for the cervical region. Foraminotomy, disectomy, of course, start with paracentral recessal, follow with central migrated. Decompression, avoid, in the literature they say avoid multi-level more than 50% stenosis, you should go open surgery, right? And the thoracic region, of course, decompression, avoid multi-level, instability, tuberous ossification of the ligamentum flavum, etc. But of course, this is right now the current literature. As year passes and we push the indications, some people will break these barriers, and this will have to change. But for now, let's stick with what's been published right now. So let's talk about also about milestones, because it's not only about number of cases, because we have so many different realities in our countries. But moving forward only, okay, to the next step, when you have mastered on what you are comfortable with the previous step or the previous technique. And this is the milestones that we propose in order to do the next surgery, okay? For example, once you have or you are really comfortable triangulation over the spinolaminar angle, you can identify the lateral border of the nerve root, and you have also good bleeding control, like the tips I gave you in my last talk, then you can progress to the disc herniation, because then the added step is mobilizing the nerve root, incising over the annulus, cutting and extracting the disc herniation, which is an added step, okay? So that's the philosophy. I'm not going to bore you with this. You can read it, of course, and these like milestones that you have to achieve in order to go to the next step, right? Also, the article includes a really nice discussion about what are the uses of, already well-established educational methods, like, for example, mentorship, BR simulation, and non-BR, right? Like haptics and cadavers. And as you can see, for example, in tiers 9 and 10, which is the most advanced and most complex surgery right now, far my knowledge goes, we don't have, really dedicated, for example, virtual reality simulation for thoracic procedures. So maybe here in this part, mentorship and non-BR is like more useful for you to train in this kind of procedures, right? So just as a matter of conclusions, the UV roadmap provides a structured training pathway, aligns procedural difficulty with surgeon's expertise to accelerate skill acquisition. Optimize patient outcomes, ensures safer, more effective UV procedures through a stepwise approach. And it's a foundation for standardization, which I believe is, the things that, if we want to have like guidelines or recommendations for people to start doing this, we should have some standardized methods in order to start learning and developing the technique, right? And before I conclude, a little reflection from for example, yesterday. During his really nice demonstration of cervical surgery, Francois told something really interesting. He said that in order to go from lumbar to cervical, for aminotomies, you need something like 100 cases. Okay, one of the articles, because in the article that I wrote, I cite all the articles that have Kusum analysis methods. And there is a very interesting article about learning curve for foraminal cervical stenosis. And the author says that you need, listen to this, 25 cases to do cervical foraminal stenosis. Why do you think is that? When you review the article, when you read the article, the senior surgeon was a master in cervical foraminal stenosis, open surgery, and also had 49 cases of UVE lumbar. What I'm trying to tell you is that it's really hard to give you a general recommendation about cases volume if you don't consider different backgrounds. So in this article, we consider all those different backgrounds, and we can democratize, so to speak, the procedure and talk about milestones. Because we can talk about number of cases, and I say, for example, okay, I have 100 cases. In how many years? 2 years. And the other guy says, oh, I also have 100 cases. In how many time? 2 months. It's not the same, no? Absolutely. Same number of cases, different times. And that is why I propose this, in order to try to standardize the acquisition of skills in UBE. And this is based on literature, okay? Of course, also experience, but also in literature. So these are the key points of the article. You can take a look. I believe that it's really interesting if you want to start doing UBE. If you are already a master, of course, it's not going to be useful to you. And that's it. Thank you so much.
Thank you, Javier. You did a very good job. I think it's necessary. It's very important to have some work like this to explain to the new UBE surgeon how you have to go the step. Just one comment, because you not differentiate extraforaminal approach. For me, for example, L5S1 extraforaminal approach is very, very difficult. In 2, 3, or 3, 4, it's less easier. It's why maybe you have to modify some stuff or to put some special.
As a matter of fact, yes, but this is in the detail part. I say that you should start doing with L1 to L4 and then moving to L5S1. As you said, of course, L5S1 it's more difficult.
But for me, it's maybe more difficult than cervical, than everything. It's why maybe I have to put 5-1 at the top.
Of course. No, excellent.
But also we can try to work with the community of surgeons to maybe to adapt some little bit stuff.
No, that's the spirit. I mean, the reason I brought this is to share this with you guys. You know, feel free to criticize, to add something, to modify. That's the objective of this talk. You know.
But you did a very good job, sorry.
Thank you.
Thank you very much. Any other question?
Yeah, just a question
Javier?
for Vincent. What do you think about this kind of journey?
I think it's absolutely necessary to come up with guidelines. Anything that helps education, obviously, is necessary. Now, maybe from my personal experience or a survey that I did, was very interesting to see that, or I basically asked, why do those that are already experts in the lumbar spine not extend to the cervical spine? And the two most reasons were fear of complications and lack of mentorship. So again, we have the same topic again. We don't have sufficient expertise close by. Now, fear of complications is not rational if you look into literature. I mean, literature obviously shows a fairly acceptable complication rate in the cervical spine if you do it endoscopically. So yeah, I think it's also fear, which on the other hand shouldn't keep us from extending to the cervical spine.
I have just a comment. If I had to follow here.
What?
First line.
If I had to, that's a nice guideline, but we have to adapt to reality too. You have to follow a guideline like that. I won't have start UBE never in my situation, because I'm an orthopedic surgeon in a hospital with neurosurgery department. I don't recruit any simple cases, so I have to start with decompression in scoliosis. But I mean, university hospitals, I was happy to have navigation to help me. So I think the main point is the mentorship, and to have somebody who can help you, because you cannot always select cases you want to operate. So just coming in the order is all.
I have a comment on this, because you're totally right. For example, if you put a far-out syndrome as it can do like a stopping in your career, you will not be able to do cervical if you don't do a far-out. Maybe you don't see any far-out in your career. It depends on the situation. But I think what Xavier has done is really important, is to publish a guideline that it's been there as an ideal situation and guides you in the difficulty and in the chances of having high-risk complications. So I think you're right, but Xavier has done
You're absolutely right, and yes, and thank you, Jose. But you know, the thing is that you don't have to go step by step if, for example, you have acquired a milestone. I mean, in the article I say, for example, let's say, a master, like Vincent, for example. I'm going to ask Vincent to go his first case as a ipsilateral because he's a master in uniportal endoscopy. So it's a pretty different set of skills and experience. He, for example, could start, I don't know, maybe doing 9 on or the 10 level tier that I proposed because he has so much experience. But then he's like, you know, having like a set of skills that he has acquired that he can measure. That you can say, okay, I mastered this step, so I'm prepared to go to the next step. And you don't need a number of fixated cases because, as you said, realities are different.
That will be probably nice to see with this society in how many environments we can apply those guidelines, because it's really nice for a fellowship program in a big center with a lot of endoscopic surgery like in Korea or maybe in some clinics here. But probably in Switzerland that won't be possible, honestly.
Of course. You know, it's also interesting because maybe it happened to you that when somebody asked for my assistance, they put a really complex case, and I say, of course, but what's the objective here? You want me to operate a patient or you want to learn? You know what I mean? Yeah. And we're talking about high volume cases, centers with high volume cases. So let's just not jump straight direct into the complex cases. Let's start by the basics. That's the idea. But of course, I feel you. As you're absolutely right. It's difficult to find a balance. Yeah.
And just another point, because you didn't speak about a common formation with an associate, with a friend, or with a team, like in a university service. And I think it's also a good point to share your formation with a friend, with a team, and with somebody else, because sometimes it's difficult to have a lot of cases like in private practice. And I think maybe, I don't know if Benjamin Bouillet is here, but I think it was difficult for him to create the emulation in the service and to share his experience with residents and all guys.
Absolutely.
Okay.